Welcome, everyone. Today, we're going to look into the neurological system and intracranial pressure management, a critical area in nursing, especially to those who work in the critical care settings, such as the ICU and the ER. So you can read the objectives today. We are going to be going over some of those, like a little review over the brain structures in the neurological system. This should be a review for you guys, as well as the 12 cranial nerves. So we're going to go through it pretty fast. Then we're also going to speak about intracranial pressure and intracranial hypertension and what the difference is between those, how we monitor that pressure within the brain, as well as things that we can do as nurses to reduce that pressure. We're also going to talk about brain tumors, strokes, carotid artery disease, and we're also going to talk about some of the different types of brain bleeds that we can encounter as nurses. So a little review, okay? So we're going to start with the cerebrum, okay? So if you remember from A&P, this is the largest part of the brain that makes up about 85% of the weight of the brain, okay? It's divided into two hemispheres, left and right, okay? But remember that both the left and the right do communicate with each other through the corpus callosum, okay? Each hemisphere controls the opposite side of the body. This is important because when you're assessing your patients, wherever their deficits are, you will know what side of the brain there might be an injury to, and vice versa. If you know that there's an injury to one side of the brain, you should be able to see the opposite side of the body you would expect that there would be some deficits. Okay, so the cerebrum is responsible for that higher brain functions like sensory information, motor functions, processing language and communication. It's also where our consciousness is, and which allows us to think, reason, and experience emotions. Now, the cortex is the cerebrum's outer layer, okay? And so a lot of people will refer to that as the gray matter. It's about 2 to 4 millimeters thick, so it's not that thick, but it's densely packed with neurons. The cortex is important for processing information for our senses, controlling voluntary muscle movements, and enabling those higher thinking, complex, critical thinking, and thinking through those deeper reasonings, okay? So just being able to understand these structures is going to, again, help you appreciate how those injuries or diseases in the different areas are going to affect the patient's cognitive and motor abilities, okay? So basal ganglia, and this is a word that I have a difficult pronouncing, diencephalon, okay? So we're going to talk about both of those. So the basal ganglia are groups of nuclei that are basically really deep within the cerebral hemispheres, okay? They play the key role in regulating voluntary motor movements, procedural learning, and routine behaviors. So you can think of actions like walking or typing that is controlled by this area, okay? So those things are the things that become automatic over time, where we don't have to think through those processes. That's where this part of the brain works. So the diencephalon sits in the center of the brain, and it includes the structures like the thalamus and the hypothalamus, okay? So if you remember, the thalamus acts like a relay station for almost every bit of sensory information, except for smell, that comes into the brain. Okay, and then it like redirects it into the appropriate cortical area. So the thalamus is kind of like a traffic control person. Okay, so the hypothalamus is the body's master regulator. It maintains homeostasis, and it controls temperature, hunger, thirst, sleep cycles, hormones, all those kind of things in its connection with the pituitary gland. Okay, it's an amazing little bitty teeny tiny, well, it's not super teeny tiny, but it's a small little structure that has such a big control over your body's functions. So the brainstem and the cerebellum. Okay, so the brainstem connects to the brain. Well, it connects the brain to the spinal cord, and it's composed of the midbrain, the pons, and the medulla oblongata. Okay, so the midbrain, what it does is it has functions like eye movement, processing visual and auditory information. The pons acts as a bridge, relaying the messages between the cerebrum and the cerebellum. Okay, don't get cerebrum and cerebellum mixed up. I know a lot of people do because they kind of look similar in their word structures, but they're different. So the medulla oblongata controls vital autonomic functions like the heart rate, blood pressure, and breathing. Essentially, the brainstem is what is keeping everybody alive by managing those like basic life-sustaining processes. The cerebellum, which is at the back of the brain, is crucial for coordination and balance. It fine-tunes those motor activities, and that helps ensure that our movements are like smooth and accurate. So, for example, when you catch a ball, your cerebellum helps to coordinate the hand movement, the grabbing, the balance of your body, the balance of your arm, and the movement to catch that ball. So damage to these areas, okay, can be life-threatening, obviously. And it's really important for you to, as a nurse, monitor your patients with injuries or diseases that affect the brainstem. We'll talk a little bit more about this later. So 12 cranial nerves overview. There is a great picture on the screen, and there are different mnemonics for you guys to remember it. Like I said, this is a review, so pause, read the screen for a review, but we're not going to spend a lot of time on it, okay? So just as a refresher, cranial nerves 1 through 4. 1 is olfactory, 2 is optic, 3 is ocular motor, 4 is trochlear. And again, pause to look at the pictures if you need that refresher. 5 is trigeminal, 6 is abductions, 7 is facial, 8 is acoustic. And then you have the glossopharyngeal, which is 9, vagus is 10, spinal accessory is 11, and the 12th is the hypoglossal, okay? Again, pause as needed. Okay, so now let's talk about intracranial pressure. Okay, so intracranial pressure, which basically basic definition is the pressure that is exerted by the fluids inside the skull on the brain tissue within the actual skull, okay? So normal ICP ranges from 5 to 15 milligrams of mercury. I'm going to pause right here. I want you guys to remember pressure 20. The number 20 with pressure is too much for anything. So whether we're talking about compartment syndrome in the arm, pressure in the eye for glaucoma, pressure inside the skull for 20. 20 is the amount of pressure that at that point, if there's 20 milligrams of mercury of pressure inside any like cavity or space, that will compress blood vessels, which means no blood is going to get to the tissue. Okay, so if you remember pressure 20, anything 20 and above is bad, okay? Anything below 20 is we can still perfuse the area. So if you just remember 20, it doesn't matter what anybody could ask you about. If you know something has a pressure over 20, like inside the eye, that's bad. Or inside the arm, like after a fracture, we'll talk about a little bit more about compartment syndrome in another lecture, but just remember 20 and over is no bueno, okay? So normal ICP ranges from 5 to 15. Obviously, elevated would be anything over that, but between 15 to 20, it's elevated, but not necessarily cutting off the blood supply to the area yet, okay? But within the skull, remember, it's fixed and it's a rigid structure. Bone can't expand like your arm can, right? Like, so the tissues of your arm, that bone that is circulating the brain tissue and the CSF and the blood that's inside your brain, the skull's not going to move. So if there's something that is swelling on the inside of that brain, the only thing that can happen is closing off the CSF, the ventricles in the brain, and then coming out the holes of the skull. Okay, so that would be around the eyes and in the back, which would then get the brainstem, and that is not good either. Okay, so the skull is fixed, okay, and so this is kind of like the pictures on the screen. On the left-hand side, so brain tissue, CSF, and blood, that is the normal kind of composite, okay? So it's typically about 80% tissue, blood is about 10-ish percent, CSF is 10%. Well, I shouldn't say it's normal, but when CSF gets bigger, something has to give. So the blood typically gives, because if the brain tissue gives, the brain tissue has nowhere to go but out, and that's not good. So the first thing that's going to happen, so if you have more cerebral spinal fluid inside the brain, then we're going to have less blood in the brain, so that we're going to collapse some of those blood vessels, and then we're not going to be able to get blood to the tissue, or it's going to be limited. And the vice versa, if you have bleeding in the brain, the first thing that's going to go is that the ventricles inside the brain are going to get compressed and small and or possibly collapse to make room for that extra blood, okay? But you see how like the brain tissue remains the same from left to right until the CSF and the blood just get too much. And then the next thing the only other thing that can happen is the brain tissue will then get squeezed out of where there's a hole in the area, and you'll start to see that periorbital edema swelling, but then it's going to start pushing on the brainstem at the back of the skull, which is down into your spinal cord. And once that happens, it's going to compress the brainstem. And what did we just say that the brainstem is in control of? Those vital functions. And so then life kind of has an issue. Okay. So in the critical care setting, we as nurses will be monitoring the ICP. And this is so important because, again, that increased ICP can lead to the decreased cerebral perfusion. We also call that CPP, cerebral perfusion pressure, resulting in brain ischemia. Because like I said, like it, like we're not going to be able to get blood places, right? Okay, and potentially life-threatening herniation. Herniation is when the brain tissue goes outside the brainstem in the back. That's called herniation, okay? Understanding ICP is going to help you anticipate and manage those conditions that can compromise the neurological functions of your patient. And so the Monroe-Kelly doctrine is just basically this. There's 3 things inside your brain: brain tissue, CSF, blood. When one, and it's just simple in the sense that when one gets bigger, something else has to give. Like one can't just get more amount without something else less, like, because it's a finite space, it's fixed. Okay. That's what that is. Okay. So intracranial hypertension. Okay. So this occurs when the ICP rises above 20 milligrams of mercury and remains elevated. This increase can compress the brain structures and reduce the blood flow, leading to the brain tissue death. The symptoms of this include a severe headache. Often patients are going to describe it as the worst headache of their life, okay? A lot of times vomiting without nausea, sometimes altered level of consciousness, in late stages definitely altered level of consciousness, and even coma. Okay, so you might also observe the papillary edema, so kind of like the swelling around the eyes during an eye examination, indicating optic nerve swelling. If not addressed promptly, increased ICP can cause brain herniation, where the brain tissue is displaced, compressing vital centers in the controlled breathing and heart function in the brainstem, okay? So immediate intervention is critical to prevent irreversible damage or death. So intracranial hypertension and increased intracranial pressure. So intracranial hypertension, IH, and increased intracranial pressure, ICP, refer to related, but they are distinct concepts. And I want y'all to know the difference between these two. So ICP is just the measurable value that refers to the pressure by the contents within the skull. So that brain tissue, blood, cerebral spinal fluid, okay, against the skull itself, within the skull. So like I said, the normal ICP ranges like anywhere between 5-15, some places will say like 7-15 in adults, okay, when measured in a supine flat position. When that ICP measurement is elevated or increased, that is when the pressure rises above the normal range, indicating like a potential disturbance in the intracranial contents. So there's intracranial pressure is just the measurement. So saying somebody has intracranial pressure, okay, everybody has intracranial pressure. So some people will say, oh, their ICP is high. Okay, yes, so it could be high, but not past that 20. Okay, does that make sense? Or it could be normal, or it could be low. It could be anything. So the intracranial hypertension is the term that we use to describe a clinical condition where the ICP is elevated for an extended period of time, and it's typically over that 20 milligrams of mercury mark, okay? Intracranial hypertension is often used interchangeably with the term increased ICP or elevated ICP, but more formally refers to the sustained or chronic state of that increased pressure within the skull, which can lead to those severe complications that we just talked about. Okay, so Cushing's triad. What is this? You might be told, oh, your patient has Cushing's triad, and you need to understand what that means. Or if you are assessing your patient and you see these 3 things, you need to be like, warning. Okay, so Cushing's triad, what it is it's a classic clinical sign of increased intracranial pressure. So without monitors inside that brain to test the pressure, we know that the pressure is probably going up, okay? So it consists of 3 findings. Hypertension, specifically a widening pulse pressure. So what is a widening pulse pressure? That's where the systolic blood pressure increases while the diastolic blood pressure stays the same or may decrease. So the numbers, when you're comparing blood pressures on a patient, the numbers between the systolic and diastolic are getting wider and wider apart. Okay, so like they may start off 120 over 80, then all of a sudden it's 132 over 80, then it may be 142 over 78, then it might be 165 over 67. Do you see how that's widening the distance between the two? That's a widening pulse pressure. Okay. So that happens when your body basically compensates to maintain the cerebral perfusion in the face of the rising pressure inside your body. So it is the systolic, it's still trying to get the blood to the brain, but it's not pulling it back as much because it's trying to do that. So there's good, like your body does this, it's kind of ingrained in it. So there's good things about it because it's trying to perfuse the brain, but then there's bad things about it because then that diastolic stays low. Okay, so bradycardia, the body, so that happens, okay, as the body is responding to the increased blood pressure, it's going to lower the heart rate, okay, because we don't need it to pump as fast, because the body is doing all this because of the ICP in the brain, not because of other things necessarily going on in the body. So this is, again, a reflective action that's going to be aimed at reducing the cardiac output. But in the context of increased ICP, it's a sign of significant neurological compromise, okay? And then the third part of the triad is irregular respirations and more specifically bradypnea, so like lower breathing. So this is a result of pressure on the brainstem. So like, remember the brainstem controls like those vital functions that make you can breathe and live. Okay, so when we put pressure on that brainstem, okay, especially the respiratory centers within the brainstem, you're going to have a decreased respirations, or the patient will. So respiratory patterns may become irregular first, and then there may be some periods of apnea or what we call Cheyne-Stokes breathing, okay? Cheyne-Stokes is where they'll like breathe, pause, breathe, pause, breathe, pause, breathe, pause, breathe. It's just irregular all over the place. Okay. So when you have those three symptoms put together, we call that Cushing's triad. Okay. And this is significant for you guys, and you need to be able to recognize this because that's basically saying that there's imminent brainstem compression, and it's considered a medical emergency. Cushing's triad basically, well, it doesn't basically, it requires immediate intervention to reduce the ICP. So this is we are notifying the physicians immediately. This patient needs to basically have the pressure inside their brain relieved. How we do that, they can do burr holes, which is going into the brain. We'll go a little bit over this later, like drilling a hole in, maybe a craniotomy, removing a plate, allowing the brain to swell a little bit. We can also give some meds that can help with some things. There's a whole bunch of things that we can do, but we need a physician to be aware of these things, okay, so they can start giving us orders. So understanding this triad is so important, okay, again, because you want to recognize these things early, okay, before we have permanently damaged the neurological function in parts of the brain, okay? So that's your job, to monitor the ICP. When we have monitors that can go into the brain to give us those measurements. So what are some of the things that can cause increased ICP? Okay, so one of the big ones is a traumatic brain injury. Okay, so then that leads to bleeding inside the skull. Cerebral edema, which is the accumulation of excess fluid inside the brain, that often follows injuries or strokes. The hemorrhagic stroke results from the bleeding within the brain. And a lot of times hemorrhagic strokes, it could be because there's an aneurysm within the brain. So like a blood vessel bursts open, or because the blood pressure was so high that it busts a couple little blood vessels open, and then you start bleeding into the skull. Another thing that can cause increased ICP is brain tumors, because they're going to take up space and they're going to compress those adjacent blood tissue areas. Hydrocephalus is also the accumulation of CSF due to impaired absorption or blockage within the CSF and the spinal cord in the brain. So that will increase the CSF volume, which then increases the ICP. Meningitis and encephalitis are also two other things that can cause increased ICP, because they cause inflammation of the brain tissue, which swelling of the brain tissue. Again, anything that's going to cause an increase in one of those three things inside the skull can cause an increase in ICP. So indications for when do we actually want to monitor ICP? Okay, so severe head injuries with a GCS, a Glasgow Coma Scale of less than 8, we're most likely going to be monitoring their ICP. Less than 8, remember, we're going to intubate. Just always remember that, because they can't their neurological function is so compressed that they probably can't protect their airway. So patients with an intracranial hemorrhage, we're going to be monitoring them for worsening conditions. We're also going to be assessing cerebral edema progression. So we want to monitor for that. So we also monitor post-operatively for neurosurgery, like any sort of neurosurgery procedure. A lot of times they will place the monitors inside the brain coming out of the skull, and that will so that you can monitor them after surgery just to make sure that everything is not increasing and that it's staying the same or going down. We also sometimes use ICP monitoring to help us guide treatment decisions and assess the effectiveness of those interventions, and also to prevent secondary brain injuries by allowing time responses to pressure changes. So some of those things I kind of alluded to this a minute ago to reduce ICP. So pharmacological, we're going to talk about the things that we can give meds first. Okay. So one of the big ones is an osmotic diuretic. Okay. Mannitol is a big one. Okay. So what mannitol does is it's going to draw the water out of the brain tissue and into the bloodstream, and then your kidneys can hopefully filter it and then get it out. So we're decreasing the volume in your system, but especially in the brain tissue. We can also give hypertonic saline solutions because that can reduce the cerebral edema as well, because there's higher, the hypertonic solution is going to, again, draw the fluid into the vasculature system to get it out of the body and out of the brain tissue. Corticosteroids may reduce the inflammation around brain tumors. We can also give some sedatives and analgesics, which can lower the metabolic demand of the brain tissue. It can also prevent agitation, which those both can increase ICP. Barbiturates may also be used because we'll use them to induce a coma in some severe cases, which again will reduce that metabolic activity and the cerebral blood flow. So we're just resting the brain so it doesn't need as much juice and blood and oxygen, so that we can allow for the healing to occur and the swelling to go down. So if you are a nurse in the neuro ICU or any ICU administering these meds, you are going to have to be super careful in monitoring the vital signs, this hemodynamic monitoring, and the lab values, because there are obviously giving like osmotic diuretics, hypertonic solutions. This can cause other issues within the body as well. Think about it. It's not just affecting the brain and the brain tissue. So remember that. Okay, so a little bit more about mannitol. Okay, it is a common, like I said, it's a common osmotic diuretic that is given in neuro ICU, definitely. So the indication, we use it to reduce elevated ICP and treat cerebral edema. The typical dosage you can see on here, we give it IV. What it does, okay, it increases that plasma osmolality, so within the blood, okay, so it's going to pull and draw the water out of the brain tissue into the vascular space, reducing that brain volume and thus reducing the intracranial pressure. So some of the side effects that can occur when you're giving mannitol, that includes electrolyte imbalances, specifically hyponatremia and hypokalemia, dehydration, obviously, hypotension, and in some rare cases, it can harm the kidneys because we're causing low blood volume and dehydration. Okay, so you need to be able to understand how mannitol works to anticipate and know what to monitor. So the med method for mannitol. So what are we going to monitor before we give it? Well, if it affects your electrolytes, we want to make sure the electrolytes are within normal, at least normal range right before we give. Specifically ask yourself, what does it do? Okay. And this is something for you guys to go and look up for. So I just said on the last page on, when we're just talking about this, that it can cause hyponatremia and hypokalemia. So if their sodium and their potassium's already low, would I give this? Possibly, yes, but then I would be replacing those things as well. Okay. So, and this is a discussion to have with the provider, but but if it's already low, I'm not just going to give it and not address the fact that those things are low. Okay. So we want to check electrolytes. We also want to check renal function if this can cause potential kidney damage, right? We want to make sure the kidneys are functioning properly so that they can filter out. We're going to be drawing this extra volume into the bloodstream, and we're hoping the kidneys then get rid of it, right? Or that fluid is going to end up right back in the tissue. Well, if the kidneys aren't working, then what good is it going to do, right? So we want to check the BUN, the creatinine, make sure those are working, okay? And then also like serum osmolality, okay? So, and then of course, we can even check because it could cause hypotension. So we want to make sure we have a normal blood pressure, right? We don't want to make sure the blood pressure is low because we're going to make it go even lower potentially. So after you give it, how do I know it's working? Well, you're going to look for a decrease in the ICP readings, the measurements, okay? Maybe an improvement in the patient's level of consciousness, maybe their neuro assessment improves, okay? You're also going to monitor urine output because the patient should be diuresing. So seeing an increase in urine production is a sign that the drug is working, right? So what am I going to look out for that bad things are going to happen? Dehydration, so dry mucous membranes, hypotension, right? Electrolyte imbalances like muscle weaknesses and arrhythmias. Okay, so they should be on a cardiac monitor. We're also looking for that acute kidney injury, right? So we want to make sure they're producing urine. All of a sudden they stop producing urine. We got to look into that a little bit more, right? Okay, there is no reversal agent for mannitol, so you got to do supportive care if for some reason you give too much or whatever the case may be. But these patients are going to be definitely on a bunch of monitors when they're receiving mannitol. So some non-pharmacological things. So what can you as a nurse do without the meds? Okay, one of the big ones is the positioning of the patient. So there's a picture on the screen, and this is about a 30-degree incline. And this is one of the things that we do to promote venous drainage in the brain, is you have the patient laying on supine on their back at about a 30-degree angle. So we're going to allow gravity to pull some of the fluid from the brain down. We don't want them sitting completely up. We don't want them laying completely flat unless there's reasons for that. Okay. Like other things like their spine is not stable. They have like an injury to that or something like that. But if we can, we're going to have them elevated about 30 degrees. Okay. You also want to keep the neck in a neutral position to avoid obstructing the jugular veins, because again, we want that drainage to come out of the brain. We don't want to obstruct things where the fluid stays in the brain, right? So turning the head to the side is not good. We want them to keep it in a neutral midline position, okay? So some of the other things we can do to lower ICP, hyperventilation. Okay, so what that does, so if they're intubated, we can breathe a little bit faster for them, okay? And you'll see RT do this. They'll squeeze the bag or increase the vent rate a little bit higher. So what this does is it just temporarily reduces the CO2 levels through controlled hyperventilation, like we're doing it, right? And that's going to cause cerebral vasoconstriction, decreasing the blood volume in the brain. But this is like short term. This is like on the way to the OR. We might breathe a little fast for them just to kind of help, like before we go and like open up the brain or whatever the case may be. CSF drainage. So we can possibly do a ventriculostomy, which will drain the excess CSF fluids. This is not something you're going to do on your own, obviously. So it's like a shunt, if you've ever heard of a shunt inside of a brain. So it can drain the excess CSF. Now, we can have these externally draining, or sometimes people have these permanently in, and they go from the brain down, they're inside the body, down through the neck, and sometimes typically it ends in the peritoneal cavity down in the stomach, and it just drains in there and your body will reabsorb it. If somebody has a shunt, they'll call it like a brain shunt or a shunt in their head. That's kind of some of the terms used. If they get a fever or if they start having really bad headaches, this is an emergency. Okay, big time emergency, because there could be a block in that shunt. And if there's a blockage or a kink in the shunt, let's say like in their neck or something, and so that CSF can't drain, then that CSF is going to start building up in the head, increasing their ICP, and this is all not good, right? So those are some things like if somebody tells you they have a shunt, we're not going to, if you're in the ER, we're not going to triage them low for anything. They're going to get up high, okay? They're going to have high triage. They're going to be seen pretty quickly. So CSF drainage. So like I talked about the CSF drainage. So surgical decompression. So in those severe cases, a decompressive craniotomy could be performed. Obviously, you're not going to be doing this, but you could be assisting with it. Neurosurgeon's going to be doing this. And that's going to be, they're going to take a piece of the skull off, and that's going to allow the brain to swell and expand safely without being compressed, okay? And sometimes what they'll do is they'll take the skull and like place it in underneath the skin of like the abdomen so that the bone stays alive, or maybe the thigh area. I've seen both, so that it can, while they're allowing the expansion, and then they'll take the bone back in few days, weeks, whatever, months, whatever, to replace it back up. They may not get the bone piece back. It all depends on why they got the craniotomy. If they had obviously head injury and skull fracture, they're probably not going to get it back. But anyways, so these patients will come back to the neuro ICU literally with like a part of their skull covered, nicely covered, but like you could technically don't poke on their brain. Like there's not going to be a skull, to protect a piece of their brain. So again, that's very specialized care, neurosurgery. You're talking level 1 trauma center for these kind of patients. Okay. Another way that we can reduce ICP is lowering the body temperature. That's going to reduce the metabolic demand and it can decrease the ICP. But I just want to state for reference, it's still under research for efficacy, so it's not widely used. Okay. So it depends on where you are and who buys into the theory and who's willing to support it and not, because there's still some places that wouldn't do this, but that is an option in some places. Okay. So now nursing interventions specific for ICP, other than like the positioning. So we're going to be maintaining the airway and oxygenation, right? Okay. We want to ensure that the patient has a patent airway, because if they have brain compression, it could be compressing on that brainstem. And so we want to make sure that they're able to adequately oxygenate and keep their airway open. If they are not able to, we're notifying so that they can be intubated. They're probably already going to be intubated, but that's just besides the point. So also going to be the person in charge of monitoring this neurological status. Is you're going to be performing regular neuro assessments, including the Glasgow Coma Scale. You're going to be checking pupils very regularly. You're going to be checking for the size to make sure that they're equal, that they're both reactive, same kind of equal on both sides kind of thing. You're going to actually limit suctioning and stimulation to the patient, because we want to limit the metabolic demands on the brain. We want to be low noise, right? Low stimulation. We're going to bundle care. We're not going to let somebody go in every 5 seconds and disturb the patient and do something. We're going to try to do things at the same time. Okay. So we're going to keep those interventions brief and spaced out. We're going to manage their pain and agitation, administer analgesics and sedatives to keep the patient comfortable and prevent spikes in the ICP due to agitation and or pain. We're also going to that positioning, like we already told. So we're going to keep that head midline, the head of the bed elevated to promote that venous return. Okay. And we're not going to allow forward, posterior, or lateral flexion. We just want a neutral alignment looking straight forward. Okay. So now let's discuss brain tumors and their causes. So primary tumors originate in the brain, while metastatic tumors spread from cancers elsewhere in the body. Genetic factors do play a role, as some inherited conditions like neurofibromatosis, that's a hard one to say, neurofibromatosis increase the risk. Environmental exposures to certain chemicals or radiation can also contribute to brain tumors, though definitive links are rare, like where you can actually say this caused that. So, anyways, we assume it is, but it's hard to 100,000% with confidence say that something from the environment caused the brain tumor. Also, radiation exposure. So any prior radiation therapy to the head, especially in childhood, is a known risk factor. And in many cases, the exact cause remains unknown. We don't always know why people get tumors inside the brain. So, in fact, a lot of times we don't, especially in children. So some clinical manifestations of brain tumors. Headaches are one of the most common, okay? They're often more severe in the morning due to the increase in ICP when lying down, okay? So seizures may also be one of the first signs, especially in adults without a prior history. If there's an adult that starts having seizures and there's no known linkage, like they didn't just detox off of alcohol and there's no head injury or something like that, or something that's like a link of something that could be cause seizures, we need to be scanning the brain to see if there's pressure being put on certain areas due to a tumor. Okay. So another sign could be a cognitive or personality change, just memory loss, confusion, or mood swings that does not fit with how the patient has been historically, like something's changed recently and you don't know what, and you can't pinpoint why. Also, nausea and vomiting result from increased ICP affecting the vomiting center in the brainstem. Okay. So focal neurological defects could also occur, like weakness, numbness, speech difficulties. And that does point to specific areas of the brain that we think that there might be an issue with. So it's important to recognize these symptoms early because we want to get a timely diagnosis so we can get treatment on board. So, some treatment strategies. So, surgical resection aims to remove as much of the tumor as possible. Okay, it's not always an option depending on where the tumor is located. Radiation therapy targets those remaining cancer cells after that surgery, or it can be used as the primary treatment when surgery isn't an option. Okay, we also can do chemotherapy. It can be used alone or with radiation, either systemically or directly into the brain. So they have like little chemotherapy like pellets that they can put into that area to kill the cancerous tissue. So we can also do steroids like dexamethasone that will reduce the cerebral edema, which could alleviate some of those symptoms. But we're also going to be focusing on the symptom management with meds like anticonvulsants for the seizures and analgesics for the pain. So this often requires a multidisciplinary approach because it's not just one physician, one expert. It includes a whole team to help meet the needs of the patient. So now let's switch gears and talk about strokes. Again, this should be partly a review for you guys. You already know some from strokes from MedSurg, but we're going to go over a little bit more of it, okay? Again, so remember, there's two different types of strokes, ischemic versus hemorrhagic, okay? Ischemic strokes come from a blockage or a clot in the artery that supplies blood to the brain, okay? Hemorrhagic strokes occur when the blood vessel ruptures, causing a bleeding to the brain, okay? Both of those types interrupt the blood flow to the brain tissue and deprives the brain tissue cells of oxygen and nutrients, which leads to injury and or death of the tissue and or of the patient. So when a patient has a stroke, remember it's a time-sensitive emergency. Like time is muscle, time is brain, time is everything, okay? The faster we get to the treatment, the better the outcomes for the patient. Some major risk factors include hypertension, AFib. We all know why AFib, because you can produce little clots and they can go all over the body, including the brain. Diabetes, smoking, and high cholesterol. So you guys need to understand that pathophysiology of the stroke and how it helps and how to recognize the symptoms. So speaking of the symptoms, stroke symptoms usually appear suddenly. Okay, these are not something that's been going on for like 5 months. Okay, so if somebody has sudden weakness or numbness, especially on one side of the body, like the face, the arm, the leg, sometimes they have difficulty speaking or they just don't understand the speech, and that is called aphasia. Aphasia, understanding speech, right? Difficulty. Vision problems, like they may have blurred vision or double vision. They might be dizzy, okay, or have a loss of balance. So that can indicate where would the stroke be if you remember what controls your balance. Cerebellar involvement, okay. So often, though, a severe headache is used to describe their symptoms, and that's a lot of times one of the first ones. This is, though, more common in the hemorrhagic strokes, but it can happen in the ischemic strokes too. So we have to recognize these symptoms and act fast. So the acronym FAST is what we teach patients and we teach people in the public. Facial drooping, arm or leg like weakness, right? There's speech issue, and then the time is like call 911, get to an ER as soon as possible kind of thing. Okay, so what do we do to manage these? Okay, so again, that FAST acronym, right? And then we have some options depending on, is it ischemic or is it hemorrhagic? Okay, so on the right-hand side of the screen, you'll see the AHA and ACLS suspected stroke algorithm, okay? Depending on where you work, you could have different algorithms. If you're an official stroke center, that we have different times. We have goals. You don't have to remember these goals unless you go work in one of these facilities. But what I want you to understand is how fast things need to happen and kind of the order of things. So the most important thing is getting to a hospital as soon as possible. Okay. So interventions should occur within 10 minutes of arrival. Okay. Really, they need to be in the CT scanner. So this says head CT completed in 20 minutes. I'm telling you right now in real life, if a patient arrives in an ER and it takes 20 minutes to get a head CT, you're kind of on the slower end of things. I would love to see everybody getting a head CT within 5 minutes. It's not always the case. Somebody might be currently getting a CAT scan, but we want to get to the CT as soon as possible. Why do we want to do a CT first? Because we have to know if it's hemorrhagic or ischemic, okay? So the first thing, if we suspect stroke, we are sending them to the CT, okay? Get them to the CT. I don't even care about an IV. I mean, I could be starting an IV while the CT tech is prepping the patient on the CT bed. I mean, do I want an IV? Sure. I'm probably going to get an IV before, but the priority is a head CT because it tells us everything about which way we're going to go. Okay, so if there is blood in the brain, so they had a hemorrhagic stroke, that just takes a lot of things out off the plate. Okay, so we can see blood on a head CT. If we don't see blood on a head CT, then we are assuming it's ischemic. Okay, we can't tell it's ischemic from a head CT. So it's process of elimination. Is there blood or not? No blood. We're assuming it's ischemic, and then we're going to go through see, that's why it says possible ischemic stroke. Okay, so we're going to look through, and then the next thing is, are they a candidate for fibrinolytic therapy? So clot busting. TPA is the most common one, but there are some other meds that we have been using more recently. But the gold standard for the past 10, 20-ish years that you're going to hear people talk about the most, that will probably be on the NCLEX more often, is going to be TPA. Okay, so the question is when did the symptoms start? Okay, if the symptoms started 12 hours ago, they are not candidates, right? Okay, so if they had recent surgery, massive surgery, they are not a candidate, because if we give them a fibrinolytic therapy, all the clots that your body has there to protect yourself from bleeding out after surgery are going to go away too. Okay, so remember, there's those different things that we have to do. So the TPA, okay, so it can dissolve those clots if given within a 3 to 4 hour, 4.5 hour time frame. The goal is door to TPA 60 minutes or less. Okay, there's so many numbers out there on times. It depends on where you work as to and what the neuro team has in their protocols for that time of when symptoms started to giving TPA. There are some places that are, the 3 hour mark. There are some places that will give it up to 4.5 hours. Again, there's variation depending on where you work. You need to follow your protocol, but just know that if it happened if the symptoms started 24 hours ago, they're not going to be getting TPA. Okay. The other option is the mechanical thrombectomy. Okay. So that is a procedure that actually goes in and removes the large clot from the arteries. We also give anticoagulants or antiplatelet therapy. That's going to prevent future or further clot formation. Okay. And also some of the things that we also do to manage the stroke is rehab, because we want to make sure that they're able to recover. And this is going to involve physical therapy, occupational therapy, maybe speech therapy. A lot of times, I don't know if you guys know this, so speech therapy often does feeding therapy as well, but occupational therapy can do that as well. So it depends on, they're both trained, by the way. I don't know if y'all know that, but it depends on how your hospital has that set up. Because the goal would be for, if there was any function lost, for the patient to regain the function would be the ultimate goal, but at least minimize the loss of function. Because remember, if you don't use it, you'll lose it. So we want to at least maintain function. Okay. So as a nurse, it is your job to quickly recognize those signs of a stroke and intervene. And I keep using the reference of an ER, but don't think that you can't have a patient that's upstairs that came in for, I don't know, like gallbladder, cholecystectomy, a gallbladder surgery, and they have a stroke like the next day. Okay. Because they haven't been moving. Maybe they took their SCDs off, all those, maybe they rejected their heparin or whatever the case may be. Or maybe they just have a clotting disorder. So don't think that the only time you could be potentially calling a code stroke would be from the ER. This can happen anywhere in the hospital. Okay. So carotid artery occlusive disease. Okay. What this is this involves a narrowing of the carotid artery in the neck area, right, due to plaque buildup or atherosclerosis, which reduces blood flow to the brain. Okay. So I kind of have like a picture here on the screen just to kind of show you like the narrowing, right, where the blood to get through. So some of those risk factors of carotid artery disease includes just age, hypertension, high cholesterol, diabetes, and smoking. So some of the symptoms that may happen if a patient has this is what we call TIAs, transient ischemic attacks. So those are, brief stroke-like symptoms that resolve within 24 hours. So it's like people will call these mini strokes. Are they true strokes? No, but it was like a miniature, like lack of blood to an area, and then it resolves on its own. Okay. So that's stroke-like symptoms without permanent damage. They go back to baseline, they go back to normal. So the diagnosis is made using a carotid ultrasound that visualizes the blood flow. I don't know if y'all know this, but ultrasounds, you can see blood flow of things. That's one of the main things that we use to see if there's like blood flow to an area or any kind of flow of fluids you can see through an ultrasound. So we'll use a carotid ultrasound to visualize, make sure the blood is flowing through. Okay. We can also do a CT or MR angiography for the detailed imaging, probably would die. But early detection allows for intervention to prevent strokes. And so let me keep going on. Next page. So management of these things. So medical management. Okay. We're going to be giving antiplatelet agents like aspirin, statins for cholesterol, blood pressure control. Okay. For these patients. So we're going to teach them and encourage them to have lifestyle modifications like stop smoking, diet, exercise. But we can actually go in and do what is called a carotid endarterectomy. Again, I can't say that very well. Endarterectomy. Okay, what that is it's the surgical removal of the plaque from the artery. Okay, so they're going in and taking the plaque out. Some people say that they rotor the carotids. It is a thing. But we can also place a carotid artery stent inside. And so they're going to it's kind of just like the stent that we place inside the arteries in the heart. They can put these in the carotids just to maintain the patency of the carotid arteries so that the blood flow can continue. So if patients have this procedure, some of the things a nurse needs to do afterwards is monitor for the complications, which can be a stroke, bleeding, airway obstruction, because we're dealing with the neck area, frequent neurological assessments because of the potential for stroke. And you also want to maintain blood pressure, very, very tight controls on blood pressure within whatever the doctor writes the order for a specific target range. You're going to also be educating the patient about those medications that we're going to be prescribing, probably long-term, okay, and how important it is to adhere to those and make those lifestyle changes. Okay, so again, nurses are super important in ensuring that smooth recovery and also preventing all those future complications that could potentially arise. So now let's talk about some brain bleeds. Okay, so there's a picture on here of 4 different types of brain bleeds, and we're going to go over 1 or 2 of them today, and then the rest are going to go over in the trauma lecture, okay? So we're going to talk about a subarachnoid hemorrhage. Okay, so what this is this involves bleeding into the space between the brain and the surrounding membrane. So you can see there's subarachnoid right there, kind of in the middle, right there. Okay. Anyways, so, okay, where was I? So it's the subarachnoid is the bleeding into the space between the brain and the surrounding membranes. Okay, so that subarachnoid space. Okay, traumatic subarachnoid hemorrhages result from head injuries causing the vessels to rupture. A lot of times these are like whiplash kind of things. Aneurysms can also cause subarachnoid hemorrhages. So that occurs when the cerebral aneurysm bursts open. Okay, so and that's more common than the traumatic, but anyways. Despite the different causes, both lead to blood accumulation in that subarachnoid space. That's going to increase the ICP, causing similar symptoms to each other. Okay, so that's why it's important, like what happened beforehand, we need to know. Okay, so understanding that the reason of what happened to cause the aneurysm or the just the hemorrhage in general helps guide the treatment strategies. Okay, so we need to get a good history. So warning signs of cerebral aneurysms. Okay, this so often, again, a sudden severe headache, often called thunderclap headache. Like it's the worst headache I've ever felt in my entire life, and I can't think, see, feel, whatever the case may be. Patients will be like, oh my gosh, I've never felt this before. Okay, so when somebody comes in complaining of a headache, you just rate it on a scale of 0 to 10, 10. Okay, we want them to we don't just stop there. Say, how is this? Do you have headaches normally? Yes, no. Whether they do or not, ask them to compare this to previous headaches they've had. Is this like the things you've had before? No, this is the worst headache of my life. That should be sending off warning bells in your head, okay? So the patient could also have nausea and vomiting due to that increased ICP. They could have a stiff neck from the meningeal irritation. Now, they can have a stiff neck if they have meningitis. Go over that later. But Stiff-necked means the meninges and within the brain are irritated. There's pressure on them. Okay. A lot of times they're going to have sensitivity to light. That's photophobia. Okay. Or photosensitivity, but basically phonosensitivity is sensitivity to sounds. Okay. So you want to, they could also have vision changes and weaknesses. Again, depends on what part of the brain that this is affecting. Okay. So we need to detect this super early. Okay. But it is challenging, but it is critical. Okay. So that we can treat these patients as best we can. So some of the nursing interventions for cerebral aneurysms, okay. Pre-op, we want to minimize the stimulation. Remember, we're going to decrease the demand on the brain. We're going to lower the lights, lower the sounds. We're going to bundle care. We're going to do everything we can because we do not want to increase the ICP, right? We're going to be doing those but we are still going to be doing monitored neurological status frequently, okay? So, the pre-op care, like I said, limiting visitors even too, okay, and activities that could elevate the blood pressure, okay. We want to keep these patients comfortable. We're going to do those frequent neuro assessment changes. We're going to be doing a tight blood pressure control. There's going to be a target range that we're going to do because we want to prevent future rupturing and or rebleeding. So now after any sort of surgical operation, we're going to try to prevent vasospasms using medications like ninevapine. Okay, I can't say these words. You don't have to remember that, med, but I'm just telling. And we're also going to be monitoring for signs of delayed cerebral ischemia. We're going to be educating our patients and their families about the risks of the procedure, what they can expect afterwards. There may be some neurological deficits. It may be temporary. It may be long-term. We don't know. It takes a while for us to kind of fully figure out what the long-term effects of the bleeding and or of the procedure can be on patients. So just remember, though, that as nurses, our interventions can be life or death for these patients, and they can significantly impact the outcomes and their prognosis. So primary versus secondary brain injuries. Okay, so we categorize brain injuries into one or two. Okay, so primary injuries are injuries that damage or injuries to the brain where the damage that occurs at the time of impact, such as a skull fracture or brain lac and hematomas. The secondary injury, this is going to be things that happen to the brain, damage to the brain that occurs hours or days later due to physiological responses like the swelling, hypoxia, or increased ICP. While we can't undo those primary injuries, your goal is to prevent those secondary injuries, okay? So again, this is kind of repeat, but this involves making sure that the patient has adequate oxygenation and blood flow to the brain, monitoring and controlling that ICB, preventing infections, preventing seizures, and doing all those little things like elevating the head of the bed, decreasing the stimulation, anything to lower the chances of ICP getting too high where it causes tissue death within the brain. So a quick little review, what we talked about today, the anatomy and the functions of the key brain structures, cranial nerves, you need to remember those. And basically that all is going to form the foundation of your neurological assessment. So you kind of understand what's happening in the brain. Okay. So we also talked about how to recognize signs of increased ICP and the importance of early detection and intervention to prevent those severe complications. The role of nurses in monitoring patients, administering treatments, providing education to both the patients and the families. We also talked about neurological conditions like tumors, strokes, carotid artery disease, the subarachnoid hemorrhage, head injuries, along with their managements, and the things that we do as nurses to manage their care. And anyways, that is all for Module 6A. Don't forget to review the readings and the learning objectives, and you guys have a great day.